to more discussing. And next, we'll be favored to hear from Dr. Don Coulter. He will be speaking on Ewing sarcoma, a historical perspective on diagnosis and treatment. Dr. Coulter is a professor and in the Division of Pediatric Hematology and Oncology, also at UNMC and the Omaha Children's Hospital. Dr. Coulter.
Thanks, Nate. It's good to see you. I remember when you were training, which shows how old I am. Can I just verify everybody can hear me and see my slides?
Yes, we can.
Perfect. I share Dr. Mammon's disclosure that I am not a radiation oncologist. I'm not even an adult doctor. I'm a pediatrician. And so I am very pleased to have been asked to share with you some ideas about Ewing's sarcoma. Specifically, what I would love to do is talk about the presentation of Ewing sarcoma, the current diagnostic and treatment options that are available for our patients, and sort of a historical perspective of where they come from. And then a brief conversation about the benefits of specific local control. And I think that's why this talk follows Dr. Mammon's talk so great, because we have both radiation and surgery that can be used as options in Ewing sarcoma. So I'd like to begin with a case, a young man that I met a number of years ago who at the time was 15 years old, and he was very, very active in cross country, and he was doing his training over the summer to get ready for cross country, and he was noticing some left-sided hip pain. So he went to see his primary care doctor, told to take ibuprofen, followed up a couple of weeks later when it wasn't getting any better. Imaging was unremarkable, and so they decided to say, take a little rest and maybe that will help. And he did that for 6 weeks, but the pain continued. And so he was reevaluated in 2017. And that brings me to one of the slides I'm most fearful of showing radiation oncologists, which is a radiograph. So as an oncologist, I can tell you that in the left hip, I see lots of stuff that I don't like. I'm sure that you would be able to describe that much better, but you can see that he had definitely replacement of a lot of the bone of his left hip with disease. This is his PET scan. And we can identify on his PET scan that he does have disease in his left hip, but he also has disease in multiple bones, including his vertebrae, all through his femurs. And so he had metastatic disease. He had a biopsy completed that revealed a small round blue cell tumor that had a very specific translocation for the EWS FLE1 gene, which tells us specifically that he has Ewing sarcoma. The rest of his clinical evaluation included a history and physical exam of identifying exactly where the pain was, where are the sites of disease that have been shown on his imaging, a laboratory evaluation to ensure that his body was ready for neoadjuvant chemotherapy, an echocardiogram and an EKG to evaluate his cardiac function because anthracyclines are going to be a portion of his therapy, and then primary imaging of the main lesion and an evaluation of whether he has metastatic disease. In the past, those images would be done with bone scans, but recent clinical trials have shown us that PET scans are not only effective in identifying whether somebody has systemic metastatic disease with Ewing sarcoma, they can also be helpful in defining which patients require a bone marrow test, which is not to be taken lightly in the pediatric population. That is a test that we would sedate somebody for. And there's been good studies that have shown that if a PET scan shows only localized disease with no marrow involvement on the PET and no systemic metastatic disease, a bone marrow evaluation is not required. So why would a pediatric oncologist be talking to you about Ewing sarcoma? Well, because the median age is exactly like our patient, 15 years of age, 60% of them are male, and 25% of them will have metastatic disease at diagnosis, which portends an incredibly poor prognosis. Also, the primary sites are usually the lower extremity and the pelvis, and so our patient that we discuss sort of fits right into what would be the hallmark clinical features of Ewing sarcoma. Ewing sarcoma can be identified on a plain radiograph. Many people will describe it as onion skinning. It doesn't necessarily have the same type of Codman triangle that an osteosarcoma has. However, that's interesting because Dr. Codman was the one who came up with the term Ewing sarcoma. It's one of the small round blue cell tumors of childhood. And so as Dr. Mammon was saying, in some settings, tissue is not the issue. this is one of those settings where it is incredibly important because there are a number of things that will look like Ewing sarcoma. So the radiographs can be helpful, but also the pathology is going to tell us, because 85% of these patients will have the EWS FLE1 translocation, which is a translocation of chromosome 11 and 22. And that'll tell us specifically that we're working with Ewing sarcoma. In the 15% of cases that don't have that specific translocation, we can still treat these as a Ewing's-like sarcoma with the same sort of pathway that I'm going to show you. So when you're in a room full of really, really smart people who know lots of stuff, it's important to try to show them something that they might not know. So it's very possible we don't know who James Ewing was. Very interesting guy, born on Christmas. He was one of 5 children, and at age 14, he was diagnosed with osteomyelitis of his femur after suffering a fall while ice skating. Because of that, he was bedridden for a number of months. And during that time, he kept himself occupied by doing his studies and working on these word puzzles that he would send back in. He won a microscope in a contest for his wordplay of Constantinople. And he told people that that microscope sort of changed his pathway and showed him what he wanted to do. And he eventually became a pathologist. And in that, he also would tell people that unfortunately, the loss of his unborn son and his wife in 1903 gave him a ton of time to be focused in the hospital. He was a wildly achieved person. So he first described Ewing sarcoma as a diffuse endothelium of bone, and he saw it in a 14-year-old girl who had it in her radius. At the time, the therapy of choice was to be surgery, but in surgery, the disease came back, and he was one of the first people who started thinking about using radiation therapy for it. But Ewing's did a number of other things as well. He founded the AACR and the American Cancer Society. He created Memorial Sloan Kettering Cancer Center. He actually died from bladder cancer. So he was in the pathology lab working on samples, and he urinated blood. And because of his hematuria, he urinated on a slide and identified his own bladder cancer. And he was one of the first patients to ever come up with advanced directives. He decided that he did not want to have an iron lung or anything to sustain his life when he died in 1944. Interestingly enough, he was the boss of a gentleman named Coley at Memorial Hospital where he worked. And this is William Coley, who's the father of immunotherapy. And this is becoming important in the way that we treat Ewing sarcoma. So Coley began his investigations when a young patient that he took care of who had sarcoma died. That patient was a friend, the family was a friend of John Rockefeller, and that gave him a lot of funding to continue what he was doing. And basically, he was taking bacterial cultures and injecting them into people to mount an immune response to the cancer that they had. So in this slide, you can see a picture of a young man who had a sarcoma of his face. And after multiple treatment with this Coley's toxin, the sarcoma itself started to resolve. So back in 1920s and 30s, the treatment that you would have for Ewing sarcoma was surgery, Coley's toxin, and radiation therapy, because chemotherapy hadn't come around yet. It was a time of prohibition. It was a time of pouring out beer and whiskey, but it was not yet the time of chemotherapy, because that occurred in 1943. And this is from the Bari air raid. So back then, the United States had signed a treaty that they wouldn't use mustard gas in World War II, but FDR was ready to if the Germans did. And so he had a number of mustard gas containers on a ship called the John Harvey, and they were sitting in a harbor in Italy when it was bombed by Germans. So when the ship exploded, all that mustard went out into the air and the surrounding area, and people were found to be myelosuppressed afterwards. And so those led to the first trials of mustard in animals, which led to the development of chemotherapy. Vincristine was one of the earliest chemotherapies that was used in Ewing sarcoma. It was actually evaluated by Eli Lilly as a diabetic therapy, but when they gave it to mice, they found that mice developed abscesses because the white cells weren't working as well. And so that's when it began to be tried as a chemotherapeutic regimen for a number of diseases. Doxorubicin was the next advancement. Doxorubicin is an anthracycline. It's the reason our kids have echocardiograms. It comes from a fungi that's around a certain castle in the Italian countryside. So doxorubicin, because the fungus causes red colors. It's also called Adriamycin because it's near the Adriatic Sea. As I said, doxorubicin can cause cardiomyopathy. And this is a picture of Lance Armstrong, who, after winning his 7th Tour de France, people were wondering, how is it possible this man can do this? And there were some theories that the chemotherapy that he received for his testicular cancer caused him to have dilatory cardiomyopathy, and he recovered in such a way that his stroke volume was better than his competitors, and that allowed him to outpace them on the mountains. Actually, the theory didn't hold because he didn't get doxorubicin, and we found out that he was doping later in years. So all of these sort of studies came together to show us that the effective way to treat Ewing sarcoma was to use alternating cycles of vincristine, doxorubicin, Cytoxan with ifosfamide and etoposide. It's an incredibly toxic regimen, and we found that compressing the therapy and giving it every 2 weeks as opposed to every 3 weeks improves survival by 10% for patients with local disease. And it's what we do for patients with metastatic disease. But the mainstay of therapy is this idea of giving systemic chemotherapy first to avoid micrometastatic disease. And local control is something that we talk about while we're giving those first cycles of chemotherapy. And it's definitively a team sport because local control can be surgery or radiation. Now, surgery is the most commonly used, but there is no randomized controlled trials that show any difference in survivability between surgery and radiation therapy. There are retrospective trials that show that radiation therapy may not be as effective as definitive surgery for local control, but nothing that's really compared the two. And basically it's a conversation with the child, the parents, the team, the surgeon, the radiation oncologist in deciding what is the morbidity of the resection, what would be the cosmesis, what would be the functionality afterwards. Radiation can be an adjuvant therapy. There are cases where we may use radiation therapy before the surgery to try to help shrink down the tumor, or we may use the radiation after the surgery if we're worried about positive margins. So radiation is definitively used after neoadjuvant chemotherapy. And this is the cycle that we have. And the gentleman that you're seeing there is a guy named Mark Herzlich. Mark was a linebacker for the Boston Eagles back in the 90s when he developed Ewing sarcoma in his right femur. And so the doctor sat down with him after his first 6 cycles of chemotherapy, as listed in the treatment compression on the left, and said, we have a choice to make. We can either do surgery on your leg, which will destroy your chance of ever having an NFL career, or we could do radiation therapy on your leg. And so he chose radiation therapy. He went on to be a long-term survival. He was the linebacker for the New York Giants, and he won a Super Bowl ring. So there are some of those types of thoughts that might come into it too, as to what does somebody want to do in the future. The prognosis of Ewing sarcoma, like we talked about in the very beginning, is very poor for people who, like our patient, who have metastatic disease. It's less than 25%. But also if they have localized disease, the site of that disease is important and portends to their prognosis because of the effectiveness of your local control. So we know that the therapy is toxic. We talked about that. We know we have these issues with local control. And so we talked about immunotherapy in the very beginning with Dr. Coley. What does that have to bear on what we're doing in the future? Well, immunotherapy is coming back around again. And there was a recent trial looking at a drug called gantenerumab. Gantenerumab is a monoclonal antibody directed against the IGF-1 receptor. And time doesn't allow me to sort of share with you the entire IGF-1 pathway, but it sits in a very specific part of cancer cells, and it's upregulated in a number of different cancers. Gantenerumab binds well to the receptor and inhibits its function. And so it was added as the backbone to systemic chemotherapy for patients with Ewing sarcoma. Here is our patient that we discussed in the beginning. You can see his PET scan on the left in July 2017, which showed his wildly metastatic disease. And then you can see in October 2017 that a great deal of his PET positive lesions had resolved after this therapy with gantenerumab. Unfortunately, the gains that we get with gantenerumab are not long-standing. It was found in this trial that gantenerumab not only didn't have an overall impact on their long-term survival, it actually increased the risk of radiation toxicity with radiation to the lung, which is a very common site of metastatic disease in Ewing sarcoma. Therefore, the trial was closed early, and we're still looking for new answers and novel therapeutics that we can utilize for patients who have Ewing sarcoma. So what are the future questions? We talked about the fact that Ewing sarcoma was defined very, very early on, early therapies, we're using immunotherapy defined by Coulter, we're using radiation therapy, we're using surgery, and then because of the evidence of the Bari air raid, chemotherapy came into be. What are we using with chemotherapy now? Well, we really do need to come up with novel adjuvant therapies. The gantenerumab trial showed us that we need to keep thinking about what type of immunotherapy we can add. But even more problematic is relapse therapies. For a number of these patients who have metastatic disease, their control is going to be very, very difficult over a long period of time. And unfortunately, there are not a lot of therapies that have been developed for pediatric patients. So a number of times we're actually trying, as terrible as it sounds, to get these patients to be old enough where some of the adult therapies can be available to them after they get to the age of 18. So identifying great relapse therapy for these patients when their disease come back is incredibly important. We talked about the need for bone marrow evaluation in localized patients and how we have pretty much understood that with the PET imaging only showing us localized disease, that may not be necessary. But a current difficulty that we have is understanding what is the correct number of chemotherapy cycles. We know from good data that anything over 12 cycles of chemotherapy is what we should be doing. However, there is a sort of ongoing argument within the children's oncology group right now between the idea of 14 cycles, which is what would be considered standard therapy, versus 17 cycles. And there's no real data between the two. There was a study looking at 17 cycles of chemotherapy, the same chemotherapy we talked about, vincristine, doxorubicin, Cytoxan, and ifosfamide, etoposide. That really didn't have a huge impact on overall survival, but there's a great deal of toxicity that comes from that. So future work is going to be looking at exactly how can we maintain good survival for localized patients while we can decrease their toxicity, and what are the novel agents that we can add for those metastatic patients that do so poorly, and how can we address relapse therapy. And with that, I thank you so much for your time, and I look forward to the panel discussion in the future.